So now we have Dr. Roxana Mehran, great director of Cath Lab, interventional trials, and expert in various aspects, particularly on anti-thrombotic therapy. So what she is going to share with us is novel anti-thrombotic promise, a better future. As you know, last year, we actually had a very less attendance, but the lecture is the time to retire aspirin. Of various lectures, the biggest, highest hits were on that lecture, the time to retire aspirin. So I'm sure it will be another big hit this time. All right, Roxana.
Thank you, Dr. Sharma, and thank you all for being here. It really is a pleasure to be here, especially with Dr. Narula's leadership. It's so wonderful to have you back at home. So novel antithrombotic regimens is what I thought should be the title, and hopefully a promise for a better future. Really important for you to note my disclosures specifically to the clinical trial center that I run here at Mount Sinai under the auspices of Mount Sinai Heart. I thought it would be important to go through the lecture. We have limited time, but I thought to make sure that I set the stage for you, we'll talk a little bit about this trade-off between bleeding and ischemic events. That's really the dilemma that we all have. And today I'll talk to you about some of the novel strategies. We spoke about the P2Y12 monotherapy as one way, but I'm really excited about new anti-thrombotic regimens like the factor 11 inhibition. We had Dr. Jeffrey Weitz here as a visiting professor, as the Simon Dack professor. And I'm working very, very closely with Dr. Bott and others and Dr. Weitz in terms of the factor 11 inhibition programs in which are both running extremely strong. So I thought it would be really good to discuss that. So let's understand that the determinants of antithrombotic therapies, especially after a percutaneous coronary intervention, is so much dependent on so many different factors. A patient's characteristics, their comorbidities, how they present, whether it's a chronic stable syndrome or a acute coronary syndrome, and what medications they are on, especially if they're on oral anticoagulants for other reasons where they need it. And then, of course, understanding the procedural aspects. All of this culminates into the antithrombotic regimens we choose, and then how we determine that ischemic and bleeding risk in making sure that we make the best choice of treatments for our patients. When do we start? How long we keep them on it? And in what way can we manipulate this to make sure that we navigate the very difficult path for our patients who are always changing? So the biggest news out of here is not one size fits all. So remember that. And I wish that it was simple, but I think now with AI, and we're going to be working very, very closely with the hospital AI to hopefully figure out a way to navigate the best possible way to predict ischemic and bleeding risk based on all of these things and understand better what should be best for whom. One of the first ways is to better understand the time course of bleeding and ischemic events after a PCI. And that a lot of it has to do with, of course, the local ischemic events that could happen that are related to the stent, the ones that are related to, it's not just that few millimeters of stents. And I hope you listened to the wonderful panel discussion where Dr. Fuster and Dr. Mehran were talking about beyond the intervention, what else is going on in the coronary and the vascularity that is all over our bodies, not just in the heart, but also peripheral vascular and peripheral vascular disease, and how there's an important plaque progression and destabilization. And of course, the ischemic events that occur both in the periphery and in the brain, and then of course, bleeding. But if you look at this, the time course after a PCI for local events are in that first 3 months, there's both bleeding and ischemic events that overlap. it looks like the local ischemic events kind of go away after 3 months. The plaque progression and destabilization continue, and hopefully, if we're doing a great job with our medical management, continue to reduce. But bleeding is a gift that keeps on giving because we keep giving them anti-thrombotic, antiplatelet regimens. And if you think about their course of needing procedures, going through other things, you're still going to have this. So again, this time course is important. And we are always looking for this sweet spot where we can find the lowest ischemic events with the lowest bleeding events. And this balance of bleeding and ischemic complications is something we're doing all the time. Over the last few decades, we have had trial, and I know that, Deepak, I think you were involved with CURE and CURE PCI way back when clopidogrel and all of that was coming on, and I know for sure Charisma. And every single time where we saw decreased ischemic events, there was a risk of an expense of bleeding, no matter how hard and how well we tried. So what else is important is that high bleeding risk patients, we see them every day, all of you in your offices. And we're very much focused on that high ischemic risk patient, but we see high bleeding risk patients. And we also know that that same elderly patient with CKD, liver disease, active cancer, those same patients who are at very high risk for bleeding and they're on a direct oral anticoagulant, they require it for atrial fibrillation, guess what? They're also really high ischemic risk. That overlap is something we have to navigate as physicians. How do we do that? How can we figure this out? Well, you try to think about myocardial infarction versus bleeding. Those are the two most prominent events that happens. And if you think about myocardial infarction, it's really an important one. We want to avoid anyone having a myocardial infarction. But when you have a major catastrophic bleed, myocardial infarction risk in association to mortality pales in comparison to a very, very catastrophic bleed. So it is going to be very important for us to avoid these catastrophic bleeds. And I think what's very important is if you look at the course of the treatment of how we can find ourselves in the best possible position after 3 months or so to really find the patients in the lowest level of the risk, and how do we do this according to time. And I think also very important is the complexity of the lesions and the complexity of the patient in our cath lab. We now have very, very good data from, and this is Gennaro Giustino, one of our fellows here, who worked very closely with pooling these studies of 6 randomized trials, 9,600 patients, where a complexity of the lesions that are being treated in, and especially in a cath lab like at Mount Sinai, a tertiary referral center where all of these patients come in, that is a patient who's at a very high risk for major adverse cardiovascular events. And the more complex that patient is in terms of their plaque morphology and the burden of plaque, they're going to have a much higher risk of ischemic events, and perhaps they should be given long-term dual antiplatelet therapies and maybe even a dual pathway inhibition where we could really, really handle those. And I think what's really important is to think about this. If you have a patient who's not at a high bleeding risk, there's more benefit if they, especially if they are at an ischemic risk. It's much more important to keep them of a long duration of dual antiplatelet therapy, especially if they have a complex PCI. If you have a high bleeding risk patient, there is no net benefit of that long-term dual antiplatelet therapy, irrespective of the complexity. And I think what we're really seeing now is this evolving change and the roller coaster of prolonging, worrying early on, worrying about thrombosis, now understanding that bleeding matters, and where we are today in an really good position of equipoise. a place where we have very safe stent platforms, a place where we now know that intravascular imaging can really, really enhance how many stents we put in, how we evaluate the plaque burden, and especially how well we deploy those stents and make sure they get a great result. And we also understand very well, based on all of these amazing clinical trials that I've put together on this slide, the understanding of what it means to stop dual antiplatelet therapies, and now an experimental approaches with shorter duration of dual antiplatelet therapy and even withdrawal of aspirin. And those strategies that are interesting are the aspirin-free strategies, where I said it's time to retire aspirin, but really the promises here are, can we reduce bleeding without increasing ischemic events? And I think we established that with aspirin-free strategies. But I'm much more excited now about factor 11 inhibition, where you are targeting residual thrombotic risk without increasing bleeding events. Is that even possible? And I almost really didn't believe it, but the biology makes sense and the data looks strong and the programs are well underway. And we'll discuss that today. So let's talk about the aspirin-free strategies. That rationale is very, very important to think about. There are important limitations of prolonging and giving patients aspirin for life. There is no question that that risk reduction, where in the past, aspirin was associated with reducing for secondary prevention, and it still is if there's nothing else on board. But now we have so many other contemporary drugs that favor and alter that patient's risk, individual risk, and maybe aspirin's effectiveness is not as great as we thought it would be. And we heard today that maybe it's now all about LDL lowering, inflammation, and maybe even LP(a) and triglycerides. Those ideas are non-thrombo, not looking at antiplatelet, antithrombotic regimens, but other pathways. Because I think we've exhausted how much more antiplatelet and blood thinners we're going to be giving our patients to stop the thrombotic complications. And we have these novel antithrombotic regimens now completely in front of us. We have potent antiplatelet regimens, and we also have thrombin inhibitors and some of the direct oral anticoagulants in combination with antiplatelets that are doing a really good job. And that the question of what's aspirin doing in the middle of all of this, on top of these regimens, comes to really a big question. And then I think at the top of this pyramid is the bleeding risk, especially the direct gastrotoxicity of aspirin. Most of us have seen this, the bleeding risk that's associated with the direct toxicity, and especially in combination with some of the antithrombotic regimens. And there are really good pharmacodynamic studies that show that when you withdraw aspirin, in presence of potent agents, you're really not seeing any issue in terms of blood thrombogenicity. We showed that in Twilight. But very important is this understanding of the assessment of platelet aggregation. And in presence of these four agonists, there was little additional platelet inhibition following stimuli, with several of the agonists in presence of a potent P2Y12 inhibitor. This is both for prasugrel as well as ticagrelor. So those data were there for over a decade, honestly. We also know that the P2Y12 receptor plays a very important role in platelet activation and amplification. The P2Y12 mediated signaling on thrombotic and inflammatory process have been well established. And of course, we also know the very important effectiveness of P2Y12 inhibitors to reduce stent thrombosis. We've seen this all the time. And so to understand that maybe the P2Y12 receptor inhibition with a very safe, with a very, very effective, durable, potent agent could have an important role. And these aspirin-free strategies now have been tested not just from the Twilight trial, which is the only double-blind placebo-controlled trial that evaluated aspirin withdrawal in presence of a potent agent. Every single one of these that are written here are showing a very, very important benefit of reducing bleeding when you withdraw aspirin without increasing ischemic harm, except for in ACS patients, a couple of, with clopidogrel, there might be a little bit of a hiccup, but certainly not in presence of a potent P2Y12 inhibitor. And that was sort of the basis of the Twilight trial, which was part of this whole group, but really one of the first ones, and probably the only one that looked at this in a double-blind placebo-controlled trial. And I have to give Dr. Sharma a lot of credit for telling me that, you know, I do this in my patients. You should be thinking about this. And of course, then we sat down and we thought about how do we take these high-risk PCI patients who are at high risk for both bleeding and ischemic complication, where the doctor wants to put the patient on a potent agent, give them an open period of enrollment of 3 months of aspirin and ticagrelor, have them come back at the end of 3 months, and if they didn't have ischemic and bleeding complications and they were adherent, then they can be randomized and enter our study in a double-blind placebo-controlled trial of ticagrelor plus aspirin versus ticagrelor plus a matching placebo. And no one knew for the entire 12 months what these patients received. No one. Not the investigator, not the patients, not us. There was only our wonderful data safety monitoring board that was watching the safety of these patients. And it was really difficult to get people to agree to something like this. High-risk patients, you're going to stop aspirin? Were you crazy? And we really, really pushed this forward, and we were able to enroll patients. And thanks to Dr. Sharma being one of the top enrollers, because it was really his idea to go ahead with this. And lo and behold, the first question was, and our primary endpoint, which we were very overpowered for, was what happens if you leave these patients? You think they're very high risk. We want them to be on these potent agents. Well, you leave them on there for another 12 months, you have a 7.1% chance of bleeding with a BARC 2, 3, and 5. Keep them on it, and that's what you get. But when you withdraw aspirin, that will come down to 4%. And this was a numbers needed to treat of like 30 patients to receive a benefit, and it really was unbelievable. Obviously, this should have been, the primary endpoint was this, and of course it was gonna be, if this didn't work, we were really off. But what was the reason why we needed over 7,000 patients in this study was to make sure that we actually had this safety. Everybody was worried. You stop aspirin, these patients are going to die. They're going to have more myocardial infarction or stroke. Well, here's what happened. Over the period of time, there was zero difference, absolutely nothing. Nothing changed for these patients. The curves are literally hugging each other throughout the 12 months of experiment. And when we saw this, honestly, I almost fell off my chair. I thought there would be like a little bit when the first time we unblinded this. So I'll just tell you one thing. There's nothing more exciting about an investigator-initiated study that you run independent of industry. No one is there, and you get to unblind on your own with your colleagues sitting in the room. Oh my God. So if you want to do research, this is the way. I know that Dr. Sharma is excited about opening up, CTO or a rotablator and all of that, but to me, this was one of the most exciting days of my research career. And I was so proud of my team, and especially the Icahn School of Medicine that sponsored this study, independent of our industry colleagues. But of course, there was a huge funding from AstraZeneca. We wouldn't be able to do this without their help. So of course, we showed that if you do this, you could have less bleeding without increasing ischemic events. And then of course, everyone is looking and unblinding their open label trials. It's not unblinded because it's open label, but they're showing very similar effects. But then we said, what about the acute coronary syndrome patients? I mean, if you look at stop-DAPT ACS, they stopped this after 3 months with clopidogrel monotherapy, and there was a hiccup. There were more. They did not meet non-inferiority. I don't know what that exactly means. Many people say, well, if you don't meet non-inferiority, then maybe you're inferior. Well, it's all about the margins and all of that, so you really have to go back, and it's the worst nightmare for somebody to say you didn't meet your non-inferiority. It is a nightmare because it means you're literally inconclusive. But in here, in Twilight, where we met every endpoint we looked at this subgroup of patients, those who have an acute coronary syndrome. And in fact, for them, it was even more important because they had much less bleeding and no change in their ischemic events, maybe even a trend towards less. And it was very, very interesting to see this. And ticagrelor monotherapy, now I'm not going to just say it was based on this particular trial, but a 2A recommendation, another great day of when you do this, and the guidelines change. And then, of course, we looked at all kinds of, like, what about the high bleeding risk patients? They also did great. They had a reduction in their bleeding without increasing ischemic harm, and especially in the complex PCI patients, that was also another very big win. So it was really a very, very exciting part. And then working together with my colleague, Marco Valgimigli in Switzerland, he and I put together an individual patient data meta-analysis of all of the trials that were available, and we were able to show that you reduce major bleeding of BARC3 and 5 when you combine all of these data together by almost 50% without any increase in death, myocardial infarction, or stroke. And I think this was a really, really big, it's now 24,000 patients, and I think it really gives you a very, very good, so if you're not using this strategy, maybe you might consider it, especially when you want to give a patient a potent agent for a longer period of time. Drop the aspirin if you're worried about bleeding, and then think about de-escalating as you move away from the first time this patient had PCI. It's an idea to think about that. And then, of course, we looked at complex PCI because that's also very important. This was all of these data together. And if you look, the complex patients have higher ischemic events, but yet when you go to a P2Y12 monotherapy, you still show a reduction in bleeding without increasing ischemic harm with a great net clinical benefit for these patients. So I think, again, very, very important to think about that. And when you put it all together, P2Y12 monotherapy is safe and effective for long-term secondary prevention compared to aspirin alone. But now let's move to the real promise of the future, factor XI inhibition. This is targeting residual thrombotic risk because no matter how well we're treating our patients, there is a limit of how much, when you can push it to the level of not having that pain. That patient will have some more bleeding. And can we do this without increasing bleeding events? How could this even be possible? Well, there's a rationale. The dual pathway inhibition has already been there. There is no question that there is a residual major adverse cardiovascular events in the best possible scenarios. And this synergistic inhibition of two essential components of atherosclerosis, whether it's factor Xa with thrombin inhibitors, which works on coagulation versus and P2Y12 inhibitors, have been well documented, especially with the work that's been done in the COMPASS trial with Dr. Bott and colleagues. And of course, no question that with a dual pathway inhibition at a low dose of rivaroxaban, 2.5 milligrams twice daily, it was plus aspirin was advantageous to single antiplatelet therapy, especially those patients who have polyvascular disease. There was huge benefit in limb events, almost a 70% reduction in amputations in these patients. And at the moment, though, we have a 2B recommendation adding a second antithrombotic agent to aspirin for extended long-term use for those patients who don't have a risk of high bleeding, but a 2A for a second anti-thrombotic regimen of 2.5 milligrams BID of rivaroxaban for secondary prevention in those patients who have high ischemic risk and low bleeding risk. So really important to think about that, and many have not incorporated this regimen in their armamentarium. But the trade-off is there, because even with the best possible scenario, with reduction of mortality, a trial that was stopped early for mortality benefit for dual pathway inhibition, there was more bleeding. The expense of bleeding was there. It still was there. So you come back to the fundamental question: is uncoupling hemostasis and thrombosis even possible? So you think about in hemostasis with initiation, amplification, and consolidation of a clot that is formed. And in thrombosis, the thought about that stable thrombus that is absolutely, and you think about all of the factors that are coming into play and going back to our hematology learning, and of course, the current regimens, the heparins that have factor 10A and 2A inhibition, right in the middle, right here in the middle pathway. The VKA that is sort of both intrinsic and extrinsic, the the direct oral anticoagulants that are factor 2A and 10A, similar to the heparins, where there are more bleeding associated with them. But when you come to factor 11 and go upstream into the contact inhibition of factor 11 and 11A, you start to show maybe less bleeding. And that is really where we are thinking about, can we target some of our patients with this new agent? And think about the fact that not only can you reduce ischemic complications, but actually have a way where you allow a beneficial effect for blood clots to form in areas where they shouldn't be forming, like in your puncture site or gastrointestinal issues. Think about that. Is that even possible? Well, we can go back to human genetics and human biology. There is some evidence to support this as a really important target. In those patients who have the human genetic deficiency of factor 11, which is 1 in 450 Ashkenazi Jews that are here in the audience, maybe, all of you can think about that, they have a reduced risk of thrombosis and they rarely experience a spontaneous bleed. So biology is telling us this could be the case. And in fact, in genetic epidemiology, in the large cohort studies, the risk of thrombosis was twofold higher in subjects with high levels of factor 11 compared to those who had normal levels. And that's really a very, very interesting observation. And now we have animal studies that show us that factor 11 inhibition attenuates thrombosis in mice, rabbits, monkeys, baboon models, and no increase in bleeding. All of this was being done work that I started to see 6 years ago when they showed me when they were cutting these the tails of the rats, and there was no bleeding, and measuring bleeding in these mice who were on factor 11 inhibition. So it was really a very, very interesting understanding of how this could be. And by the way, as soon as these observations were being made, that there were important strategies to target this, this important arena. There are antisense oligonucleotides that reduce the hepatic synthesis of factor 11. There are antibodies that bind to factor 11 and block the activation and the activity. And then there are small molecules, and we're going to talk a lot about those because those are the programs that myself and Dr. Bott are working on, where you bind reversibly to the active site of factor 11 and block its activity. So a lot of excitement in this arena. So here's what's going on. Take a look. I mean, unbelievable number of studies that are ongoing right now for factor 11 inhibition. And it's going to be, I know for each of the program, there'll be at least 40 to 50,000 patients enrolled in multitudes of arenas, whether it's atrial fibrillation, stroke, ACS, and now we're even thinking about those patients who are at very high bleeding risk, who have atrial fibrillation, in whom they are not receiving anticoagulants. And this is all very, very exciting to see the multitudes of programs. And then you see the ones here, these are the antibody ones, and we'll discuss those. But the Librexia program and the Oceanic AF and the Oceanic programs and the Librexia programs are the ones that I'm involved in, but there are multitudes of these that you could see that are ongoing. So let's start with the Oceanic program, which is starts first with Pacific AF. I'll just discuss some of these because we have some of the phase 2 programs that are really exciting. This is asundexian by Bayer, and they looked at the different dosing of asundexian versus apixaban in 750 patients who were randomized to either 20 milligrams, 50 milligrams, or apixaban, and they showed complete inhibition of factor 11 activity with both the 20 and 50 milligram dose, but there was less bleeding compared to apixaban in these patients. Of course, there's no efficacy data, and this is the phase 3 trial that will come for the atrial fibrillation study. In acute myocardial infarction, asundexian was looked at by 10, 20, and 50 milligrams, 1,600 patients. On top of dual antiplatelet therapy, there was not a significant increase in bleeding, but there was no signal towards an improvement of MACE reduction, although they're not really at all powered for this. And at the moment, this particular program for ACS is being evaluated whether it's going to move forward or not because they didn't see any kind of a signal. But I'm hoping that they will come back and do this as well because it's important to think about possibility to evaluate this in a much larger trial, especially the 50 milligram dose, which I think would be very interesting. The phase 2 program of, I already showed you this. Oh, sorry, I'm going backwards. Pacific Stroke is the other phase 2 program in the stroke arena. This is non-cardiometabolic ischemic stroke. 1,800, these are like phase 2 programs just to figure out the dosing. There's a lot of work now. The phase 2 programs almost are as big as the old phase 3 programs, but they're really, you need to see how much work is being done in developing these drugs. That's why at the end of the day, you see these higher prices for these because it literally is billions of dollars put into these. And in this Pacific Stroke program, of 3 different doses versus placebo, 1,800 patients, they observed no significant increase in bleeding or hemorrhagic transformation of stroke. Imagine that. And in the exploratory analysis, that 50 milligram asundexian dose seemed to reduce ischemic stroke among patients with atherosclerosis. This program is ongoing now with a much larger outcome study. So very, very exciting. So there's going to be the Oceanic AF, 18,000 patients, phase 3 program with a very, very robust program looking for hard endpoints comparison to apixaban. And then the stroke program is this phase 3 placebo-controlled on top of standard of care antiplatelet therapy in 9,300 patients with non-cardiometabolic ischemic stroke, and these are actively enrolling at the moment. The milvexian program is also this is BMS Janssen, J&J program, and this is the one that I'm integrally involved, working closely with many of our investigators. Multiple dosing, symptomatic ischemic stroke, and bleeding outcomes. They found a very, very interesting evaluation between the doses of 25 milligrams to 100 milligrams, where they did show a very, very good evaluation of less ischemic strokes, and they're really looking at, and they are already ongoing and enrolling in the major program of the phase 3 programs that is on 3 areas, and I'm just going to tell you, I'm only showing you the Librexia programs here, is in stroke prevention, secondary stroke prevention, acute coronary syndromes, as well as atrial fibrillation. And you see the dosing that's going to be done. 15,000 patients in the stroke program, 16,000 patients in the ACS programs, and almost 16,000 patients in the atrial fibrillation program. I'm hoping that we could bring these to Mount Sinai and that you also will have ability to send us patients and enroll them in these important clinical trials. There's also the monoclonal antibodies that we talked about. There is obviously very important for venous thromboembolism. And by the way, venous thromboembolism programs are also ongoing. The VTE prevention in TKA was in the New England Journal of Medicine that was just recently published, showing a very, very good benefit for those patients, as well as ongoing trials in atrial fibrillation, the Azalea and the Lilac study. And of course, these are very important to note that they are seeing, and there will be a result at AHA 2023 with the 1,300 patients who had over 21 months of follow-up with excellent factor 11 inhibition with the 150 milligram dose of abelacimab. And I think this is going to be very exciting to see. So, to go back to the novel strategies and a promise to a better future for all of us and navigating the field, think about aspirin-free strategies. Put your patients into the different buckets that has to do with bleeding and ischemic risk. If you have a patient who's at a high thrombotic risk, please don't ration dual antiplatelet therapies. Give it to them for the prolonged period of time. Think about low dose, the dual pathway inhibition with low dose rivaroxaban. On the other side of the coin, if your patient is at a low thrombotic risk but a high bleeding risk, ration it, shorten the duration, de-escalate, and watch out for the bleeding. You will do them more harm. In those who have overlapping risk of thrombotic and bleeding events, think about those novel strategies of a short duration of DAP followed by a P2Y12 monotherapy, or using genotyping or platelet function testing to de-escalate your potent agent to a less potent agent or dropping down. And factor 11 is going to be really interesting to see. Obviously, we're very excited about targeting residual thrombotic risk without increasing bleeding events. Can you imagine that this is even possible? And not only in VTE prophylaxis, but also in atrial fibrillation after stroke, after a myocardial infarction, with really, really great findings, and now with massive studies ongoing. So I think the future is quite bright. And just when you thought, okay, that's enough antiplatelet regimens, we're still going on to do more. Thank you so much for your attention.